Welcome to this lecture on PET-CT myocardial perfusion imaging. Here are the objectives for this lecture. Myocardial perfusion and viability can be assessed with PET cardiac studies. If the MPI studies are gated, it can assess the left ventricular function and wall motion. PET MPI has better resolution than SPECT imaging. It's always performed with pharmacologic stress due to the shorter half-life of isotopes. All radiopharmaceuticals in PET decay by positron emission. This results in an annihilation reaction with a nearby electron. It emits two 511 keV at 180 degrees from one another. PET MPI agents include nitrogen-13 ammonia and rubidium-82. PET viability agent is F18-FDG. Some of the benefits of PET MPI over SPECT imaging include lower effective radiation dose, an excellent image quality. PET has improved sensitivity and specificity for coronary artery disease, a high signal-to-noise ratio, high count rates, high spatial resolution, and contrast resolution. PET has less attenuation artifacts and less false positives. There is less GI tract interference with PET, and PET imaging is more accurate, especially for obese patients and those with large chests. It more accurately identified multi-vessel disease and has a better prognostic value. Additionally, PET MPI imaging allows for myocardial blood flow reserve calculations. This allows for a measure of regional and global blood flow. This will show epicardial disease and microvascular disease that is not otherwise detectable. This slide shows a comparison of SPECT versus PET imaging. This is the same patient scanned with SPECT and then scanned with PET imaging. You'll notice that there is a false positive on the SPECT imaging, as there is an artifact that appears on the stress images in the anterior or anterior apical region. However, you do not see that on the rubidium study. Patient prep for cardiac MPI studies with PET is very similar to the myocardial perfusion studies with SPECT. Patient will be instructed to void prior to imaging and remove all metals and objects that may attenuate in the field of view. Patients should be instructed to have no food or dairy products for 4 hours prior to the appointment and no caffeine for at least 24 hours prior to the appointment. It should be communicated with the patient that no caffeine includes sodas such as Coke, coffee, including decaffeinated coffee, teas, chocolates, and any medications that contain caffeine. The patient should be instructed to withhold any theophylline-containing medications for 48 hours. And then when the patient arrives, the technologist will start the IV and place the EKG leads. The establishment of the IV line in the forearm, ideally closest to the rubidium cart. The IV should be at least 20 gauge and should be pressure rated up to 50 to 65 milliliters per minute flow rate. The technologist should use 2 sets for lead setup, a 12-lead EKG for stress monitoring, plus a 3-lead EKG connected to the scanner for gating purposes. And then an automatic blood pressure cuff should be placed on the patient. Before taking a resting blood pressure cuff, the patient should have a chance to lay down on the camera and get comfortable and back to a resting state before the first blood pressure is taken. This is an important step because it can influence the resting blood flow levels if myocardial blood flow reserve is being calculated. Rubidium-82 is a potassium analog. The method of uptake is very similar to thallium 201. It is actively transported into the myocardium via the sodium potassium or ATP pump. The critical organ for rubidium is the kidneys. It is excreted through the urinary system. It is produced by the strontium-82 rubidium generator. This is very beneficial because you do not need a cyclotron in close proximity. And the daughter radionuclide has a half-life of 72 seconds. The parent radionuclide is strontium-82 with a half-life of 25 days. The generator must be replaced every 4 weeks, about 28 days, and it can be eluted every 10 minutes as needed. It is injected using an infusion system connected directly to the generator. This is due to the short half-life of the rubidium-82. So the patient is connected to the generator. You do quality control in the morning to make sure there's not too much strontium breaking through. And then from then on out, the rest of the day, it's attached directly to the patient with every infusion. Rest imaging is always performed first. You never do stress first images. So it's always resting first, patient gets stressed, and then their stress scan. The dose will range from 10 to 60 millicuries for rest and stress. It's typically the same dose for rest and stress, so this is different from technetium-based agents as well. And the actual dose depends on which generator you're using and the camera manufacturer, as well as the facility guidelines. So some of them use a weight-based dosing where they give a little bit higher dose to people who have a higher BMI. And some of them have to use a lower dose because the camera is so sensitive. You don't want to have a really high count rate and then have excess dead time on the camera. So the dose will range a little bit, but whatever it is for that facility, it will be the same at rest and stress. Now the injection is in 50 milliliters of saline. It's followed by 50 milliliters. So whenever you are injecting that into a patient, you need to have a IV that is 20 gauge at least. You want a larger bore needle, and then you also need it to be rated for 50 milliliters per minute at least. 65 is better, but you need to make sure that the supplies you're using are able to handle that infusion from the generator. And the expiration on the label, it will be on the label of the generator. So the entire elution decays within about 15 minutes. That's one of the reasons it goes straight to the patient. It doesn't sit around and you have to use it within a certain amount of time. Expiration is on the label of the generator, and then it goes straight into the patient and it decays within about 15 minutes. The timing of that is it is injected over 30 seconds. The scan is about 70 to 90 seconds after the rubidium infusion. If the patient has a decreased ejection fraction or known congestive heart failure, then it is prudent to add a scan delay, and you would increase that time by about 90 to 120 seconds, just a minute and a half to 2 minutes-ish before you start your scanning. That will give it more time to clear from the blood pool and concentrate into the myocardium. So in the summer of 2011, 2 patients that had undergone rubidium-82 imaging were detected at 2 different border crossings by Department of Homeland Security. They were scanned 66 and 106 days earlier with rubidium, and the half-life is only 75 seconds. So the half-life of strontium-82 is 25 days, and the half-life of strontium-85 is 65 days. So it was concluded that those patients actually had an excess amount of strontium in them. And Bracco voluntarily recalled the generators, and there was a lot of revamping of the cart to make sure that those things couldn't happen, investigating why that happened. And it turned out that patients were being injected, or the generator is being eluted with lactated ringers or other doped saline that wasn't just 0.9% sodium chloride normal saline. It had other things in it like calcium or potassium, and those other elements that are in there alter the chemical reaction that's happening within the generator elution, and it will cause excess breakthrough of strontium. So the carts are back on the market with increased QC requirements. There's lower contaminant breakthrough limits and increased volume required per injection. And it's an absolute rule that it must be eluted with a 0.9% sodium chloride. The Bracco cart has a scanner that goes with it that you actually have to scan the saline. In the system, we'll double check that that really is saline and not any kind of lactated ringers or anything like that. So there's extra checks and balances now to make sure that patients are given sodium chloride. And this is what the Bracco cart looks like. This is the CardioGen. And over here on the right, you see the actual generator. It's very small, and it's got inlet and outlet ports here. So one goes in, saline washes over the column, and then the rubidium comes out. And there's all these yellow tags. There's a couple tags that go on the saline. This is where the saline is hanging right here. There's a yellow tag on there to double check that it really is saline. And then the 1700 cart, which is the newest model at the time of this recording, it has a barcode scanner to make sure that that it truly is saline. And typically, best practice is that it should be checked by 2 people to make sure that it really is saline. So the quality control procedure for the rubidium cart is to elute the generator and discard the eluent. You always discard it on the first thing of the day. You'll wait 10 minutes, elute the generator into a test vial, note the exact time, measure the dose calibrator, measure the rubidium in the dose calibrator on the rubidium setting, note the exact time and correct for decay. Allow the eluent in the vial to stand for 1 hour, measure in a dose calibrator on the appropriate setting to measure the strontium, calculate the amount of strontium in 82 in the same sample based on measurement. And so that is the standard oldish way to do the QC on the generator. With the newer Bracco carts, you will elute it into a test vial. You set a timer for about 3.5 minutes, 3 minutes and 45 seconds, somewhere around in there. And then you do still put it in the dose calibrator, but you will record the amount of rubidium that's in that dose calibrator at exactly 3 minutes and 45 seconds after elution. And then you actually don't have to do those calculations for you. The cart will do it. So you just plug in the number that you assayed the rubidium to into the cart. It will tell you that fraction or that proportion of strontium versus rubidium that's in it based on the total activity that came through and what was recorded in the dose calibrator. So it's a lot easier now. Instead of waiting 10 minutes, you wait about 3.5 minutes, and then you just plug in the number that was on the dose calibrator into the cart. And then determining breakthrough is done by dividing the microcuries of strontium-82 by the millicuries of rubidium. It cannot exceed 0.1 microcuries, and then you repeat that for the strontium-85. But like I said, you don't have to do that math anymore because it is built into the newer cart. With the latest version of the Bracco CardioGen cart, you will perform the generator eluate test, record each generator eluate volume, including the waste and test bottles, and then keep a record of the cumulative eluate volume. The cart does do this for you, and it's displayed on the left side of the screen. Determine the rubidium-82, strontium-82, and strontium-85 levels in the eluate once daily before you administer the drug to any patients, and any additional daily tests after the detection of the alert limit, then you would need to repeat the QC. The alert limits I want to specify do not mean that you need to stop using the generator. It just means that you are approaching the limit where the strontium breakthrough may be approaching the levels where you can't administer it to a patient. So it's kind of like a warning. But the alert limits are when you have 14 liters of saline that has been washed over the generator, or the strontium-82 level exceeds 0.002 microcuries per millicurie of rubidium, or the eluate strontium-85 levels exceed 0.02 microcuries per millicurie of rubidium. So if any one of those conditions are met, then you have to perform the additional daily test at time points determined by the day's elution volume, and the tests need to be performed every 750 milliliters. So if you're, you'll need to watch that, and it will probably alert you. It should alert you, but you would need to stop and repeat the QC to make sure that the limits have not been exceeded. Now, the absolute stop use of the generator is if 17 liters of saline have been washed over the column, it's been 42 days since calibration, the eluate strontium-82 exceeds 0.01 microcuries per millicurie of rubidium, or the strontium-85 level exceeds 0.1 microcuries per millicurie of rubidium. So if any one of those four conditions is met, then the generator is expired and you cannot use it at all. Now, all of the rubidium tests are done using pharmacologic stress testing. Because of the short half-life of the rubidium, patients cannot walk on the treadmill. So the absolute contraindications for regadenoson stress testing are ingestion of caffeinated or decaffeinated beverages, chocolates, or caffeine-containing medications within 12 hours of the test, ingestion of sustained acting theophylline products within 24 hours, sinus node dysfunction, active wheezing audible prior to initiation of the test that's not relieved by the use of their inhaler, allergy to dipyridamol, or acute myocardial infarction within 48 hours of the test, and severe aortic or mitral stenosis. If any one of those conditions apply, that's an absolute contraindication for regadenoson. I want to point out that the use of decaffeinated beverages and chocolate are also absolute contraindications, and that's because a lot of decaffeinated beverages actually have a little bit of caffeine in them, and that could result in the person being a non-responder, meaning they do not respond to the vasodilation. Now, relative contraindications are a general history of asthma, allergy to aminophylline, ingestion of sustained release theophylline products between 24 and 48 hours, resting systolic blood pressure less than 90, ingestion of decaffeinated beverages within 12 hours, ingestion of caffeinated beverages within 12 to 24 hours, presence of greater than a first-degree heart block, ingestion of full meal within 4 hours of the test or partial meal within 2 hours, and moderate aortic stenosis. I also want to point out here that the patient does have to be NPO, but rubidium is different than Cestamib and Myovue or tetrafosmin. So when the patient has anything at all in their stomach, it's going to cause their stomach muscles to start working. You know, your stomach has chemical and mechanical digestion. So anytime anything goes into your stomach muscles are going to start working. They're going to start churning whatever's in your stomach so that your body can digest it. So if you drink water and that water hits your stomach knows something is in it, your stomach is going to start digesting it, and your stomach muscles are going to start working. So if a patient has any water within 4 hours or so of the test, then their stomach is going to be working. Their smooth muscle of their stomach is going to take up the rubidium. That can interfere with the test a little bit, even though PET imaging is much better at separating the anatomy. If the stomach is very close to the heart, it may overlap a little bit and that may interfere with the test. So best practice when we tell the patients to be NPO, that means absolutely nothing by mouth, not even water. Some patients have to take their tests or their medication in the morning. So if that is the case, then they need at least 2 to 4 hours after they've taken that medication before they can have the test, and they should be NPO during that time. So the rubidium protocol starts with identifying the patient, taking a history, and starting that IV. Remember, the IV needs to be at least 20 gauge with pressure rated for 50 to 65 milliliters per minute. Position the patient supine with their arms above their head. And then if you're doing a transmission scan, you'll do the transmission scan at that point. Otherwise, you'll do the CT for attenuation correction. I want to point out that when you put the patient on the table and they're laying supine, this is when you connect the 12 lead EKG for the stress monitoring and then an additional 3 lead EKG for the gating on the camera. At this point, once the patient is positioned on the table and they've had a minute to calm down and relax from the exercise of climbing on the table, and they're maybe not as nervous, that's when you would do the first blood pressure. And it's typically once you push them in under the camera and they're in position, that's when you would take that first blood pressure. If the patient has a really high blood pressure at that point, not really high, but anything that's over like 140, if their blood pressure is high at that point, then it's best to wait a little bit and let them calm down and repeat it before you actually start the test. If you're doing myocardial blood flow reserve, that high resting blood pressure, that can affect the myocardial blood flow reserve numbers and give a falsely low reading. So you want to make sure that the patient is relaxed before you do that. Once you start, you either do the transmission scan first or the CT, depending on what it is. The CT helps set the patient positioning and scan limits to include the heart. And then you'll begin infusion of the rubidium 82. It's typically about 30 to 40 millicuries, and you'll start the camera. If you're doing myocardial blood flow with it, you start the camera right away because you want to catch that bolus. If you are not doing myocardial blood flow, you're just doing perfusion, then you wait about 2 minutes. There's a 7-minute acquisition in the bed position and one bed position. If you are using some newer cameras that are a little more sensitive, you may be able to cut that down to 5 or 6 minutes. But a 7-minute acquisition gets you adequate perfusion counts. List mode can be done to catch the flow if you're doing myocardial blood flow reserve. Otherwise, you wait about 3 minutes from the infusions to scan the patient. At that point, you want to check the images before you proceed to the stress part. If it for the pharmacologic stress, you can either use adenosine or regadenoson. It's about 2 minutes after at peak vasodilation is when you would begin the stress infusion, which is typically also 30 to 40 millicuries. Again, you'll use the same dose for rest and stress. So after you administer the adenosine or regadenoson, you want to wait 2 minutes to make sure that it's at peak vasodilation before you start. If you're doing list mode to catch myocardial blood flow reserve, you will start right away at that 2 minutes. Otherwise, we'll go ahead and infuse the rubidium, and then you wait 3 minutes and do the 7-minute static image. It is optional to repeat the CT or the transmission scan if you believe that the patient moved at all during their stress portion, and this is useful to correct misadministration. If it's ever a case where you do need to repeat that CT or transmission scan because the patient moved, then you would repeat that, and then you have to manually select that as the the CT or the attenuation correction data for that portion of the study. So you would need to select that for the resting. You can also a lot of times correct a little bit of motion before you send it to your processing station. Most processing stations you cannot correct for motion or misalignment once it gets to the processing station step. You need to do that on the scanner. Because of the way that PET images are acquired, they're not SPECT images. They're static frames or more like planar imaging, where you're just acquiring for 5 minutes on one bed position or 7 minutes on one bed position. Because of that, you can't really correct for motion during the scan. But if the patient moved and there's a misregistration error on the CT, if they moved like between the CT and the MPI study, then you can correct for that misregistration error. These are the acquisition parameters, and I know that these are a little bit difficult to read. I want to point out too that these may change a little bit based on the system that you're using or the scanner model. But typically the matrix size is 128 by 128. There are quite a few things that are in common regardless of what scanner type you're using. One of them is the matrix size 128 by 128. Recon method is the ordered subset. This is the iterative reconstruction, OSEM. There are 20 subsets with 2 iterations. The 3D filter is going to be Butterworth 6 with a cutoff of 20. That may change a little bit. And you want to apply the corrections for decay, dead time, scatter. It's typically acquired in 2D mode with one bed position, and emission time is anywhere from 5 minutes to 7 minutes. And then the CT scout times are usually pretty set. Gating is going to be pretty set at 8 bends per frame with beat rejection. And the total acquisition time is 7 minutes in list mode. The CT parameters will pretty much be about the same depending on which scanner you're using also, but it'll have a 5 millimeter slice thickness. KVP will be 120. MAS is set at 40. This is a low dose CT. And then dose optimization with auto MA is usually turned on if you have any kind of dose modulation. And then the scan type is going to be a helical CT. This is the standard workflow for the Rubidium MPI protocol. A is for a PET only scanner and B is for the PET CT. So if you look at A, patient will undergo the transmission scan. This usually takes about 3 minutes. However, if you don't have the patient positioned correctly, you'll need to repeat it. So you always want to double check before you move to the next step. And then you'll start the rubidium infusion. This one says 20 to 60 millicuries, but whatever your facility's prescribed dose is, you would start that infusion. That infusion takes a couple minutes, and then you start the gated rest. Gated rest will take about 6 to 7 minutes. And then there's a little bit of a break, 1 to 2 minutes while you're setting up. The patient will receive their vasodilator with whatever vasodilator drug that your facility is using. And then about 2 minutes later, at the peak of vasodilation, you'll start the rubidium infusion again. The person will receive their gated stress images, and then at that point, you can repeat the transmission scan if you need to. Whole test takes about 30 to 33 minutes when you're doing PET standalone procedure. If you're doing PET CT, the CT is much faster, so everything gets moved back a little bit. CT is first, then you have the resting perfusion, resting scan. That takes the same amount of time while you're setting up for the vasodilator. 2 minutes later, at the peak vasodilation, you start the rubidium infusion again and then perform the stress images for the same amount of time. And then you can perform that optional CT afterwards if you need to. When you're doing it with PET CT, the whole test takes about 25 minutes. Now, there are several different types of scanners on the market, and there's a couple different types of processing, but this is showing you on a Philips Gemini time of flight with the cardiac, and it's using the Emory toolbox for processing. So you will see that the slices should pretty much align themselves. You can move it and readjust it if you have to on all the processing software. And you'll have stress on top, rest on bottom, just like SPECT is. And then over on the side, you get the quantitative data that's very similar. It'll give you the percentage of thickening. It'll give you the 3D models, the sum stress scores. Ejection fractions will be built into it for stress and rest and the sum stress scores. If you're doing myocardial blood flow reserve, it will give you it'll give you that information as well. And then you also get the analysis of any ischemia that might be there and those subtraction issues or degree of reversibility. So this is another patient. This one is showing you their, notice that the heart on stress is more egg-shaped. First of all, you do see this abnormal area of increased uptake up here, but then you also see that the heart is more oblong or egg-shaped, and that usually indicates that there is some kind of motion that's occurring. And you always want to look for contralateral defects when you're looking at motion. So you can see that this one, you can kind of see there's a straight up defect right there in the anterior wall of the left ventricle, and then you also see a contralateral kind of straight across, almost looks like crosshairs, and that usually indicates that there is some motion on the scan. So cardiac PET image findings are very similar to MPI SPECT, except it's more accurate and we get a ton of information. A normal perfusion will have uniform distribution throughout the left ventricle. Right ventricle may or may not be visualized. With SPECT imaging, recall that it is not necessarily a normal finding to see a right ventricle, especially a right ventricle that is showing up as really perfused and large on the SPECT images. But for cardiac PET, that really isn't the case because it's rubidium and we have really good, better imaging with this, with PET imaging. It's normal to see the right ventricle, and so that's not something to be alarmed about if you see it on PET. Areas of myocardial infarction will have a match defect on stress and rest. This was a fixed defects, also known as not being reversible. And then the areas of myocardial ischemia will have a mismatch defect where the defect will be seen on stress, and the rest or redistribution images will look normal. Areas of hibernating or stunned myocardium will have a match defect on stress and rest. And then if an FDG study is followed, then it will have refilling seen on that test. Apical thinning is something that shows up, it's a real thing, and it's something that shows up in older patients on PET images. So it is normal to have that. And basically what happens is the apex of the heart will appear thinner. This is due to better spatial resolution and iterative reconstruction. So this is not an abnormal finding. And if physicians are not careful, then that can be mistaken for ischemia because a lot of times it will show up a lot thinner on the stress than it does on rest, but both of them will appear thinner. So it can easily be misconstrued by a reader who is not real comfortable or educated in apical thinning. But that is a normal thing that occurs with aging. Motion will have a contralateral defect, almost like a bullseye, or the heart may appear egg-shaped. There is no breast or bowel attenuation, and there is no cardiac creep because the patient is not actually exercising. Misregistration errors between the perfusion study and the CT will create artifacts. It depends on where it's misplaced to, but most commonly this happens in the anterior wall. It'll look like an anterior wall defect. Like I said, it is normal to see the right ventricle. And the most common error for misregistration is the appearance, like I said, of an anterior wall defect. If you see that, double check the alignment on the Fusion page or your processing software. This can't be corrected on the processing software and needs corrected on the acquisition scanner. Also, you cannot motion correct on PET like you can on SPECT. It is more of a static acquisition. TAD ratios are not as impactful because everyone is pharmacologic and the myocardial blood flow reserve is a lot more reliable. So this is an example comparing SPECT and PET images. You'll notice that in patient A in the top left-hand corner, that SPECT study is showing that there is an inferior or inferior lateral wall defect seen on stress that's not seen on rest. But when the same patient is scanned with the rubidium PET, you see that the heart is completely normal. And this is partially because of the filter back projection, the increased attenuation with technetium, and just the overall acquisition and reconstruction of SPECT imaging versus PET. And then with B, you have also very similar. Patient has a defect on the anterior wall, and it's kind of questionable in the inferior wall. But if you look at the PET images, you see it's much more pronounced, and that is because you have better spatial resolution. So this is a good illustration to show you that the spatial resolution of PET really is so much better that it increases the reliability of the results. It's much more sensitive to true positive and true negatives, and you avoid a lot of the false positive and false negative studies. So PET is much better, especially when you add myocardial blood flow reserve to it. You get a much more accurate picture. Now to shift gears a little bit and talk about nitrogen-13 ammonia. This one is cyclotron produced and has a half-life of 10 minutes. The short half-life means that a cyclotron needs to be in the near vicinity and the and have radiochemical synthesis capabilities. This is a huge restrictor for nitrogen ammonias being adopted into mainstream. There is a company that makes a mini cyclotron, but the mini cyclotron still requires a full room. It's not something that can sit on the countertop or on a cart like the rubidium generator can. So it still takes a lot of extra space. It also expires 1 hour after it's made. And then method of localization is simple diffusion, and it will simply diffuse across the cell membrane of the myocardial cells based on that oxygen exchange within the cells. The critical organ is the bladder. It is urinary excretion. Dose range is 10 to 20 millicuries at rest and stress. This is another one where the patient will get the same dose at rest and stress. And the scan begins about 1.5 to 3 minutes after injection, very similar to the timing of the rubidium. This slide is showing you the workflow for rubidium versus ammonia. So you will see in the ammonia one down here at the bottom, the patient will get the SCOUT and the CT for attenuation correction. The resting scan is slightly longer at 10 minutes. And then it also has a stop time where you wait for 30 to 50 minutes between. And that's to allow the ammonia, the nitrogen to decay before you give the second dose. And so this scan actually takes a lot longer, about an hour or so longer, typically, than the rubidium study. A lesser used radiopharmaceutical is oxygen 15 in water. The half-life for this is 2 minutes. This, because of the really short half-life, requires a cyclotron in the near vicinity, and the half-life is so short that it severely limits the use of the radiopharmaceutical. This is still mostly only used in research settings and academic institutions. This is an example of a rubidium test. The TID ratio for this patient was 0.96. Remember, the TID ratio does not have as much impact on cardiac PET MPI as it does from SPECT MPI imaging. And that's because typically, just because of the pharmacodynamics and stuff of the drug, it just doesn't have as much of an impact. And this is a normal study. Now I want to talk a little bit about flurpiridaz. Flurpiridaz at the time of this video is recorded is still pending FDA approval. It's expected by the end of 2024, although it keeps getting pushed back and delayed. It is still in clinical trials. It is similar to tech-based agents, but it has improved sensitivity and specificity. It's an analog of a non-toxic insecticide, which inhibits the mitochondrial complex 1. It is being evaluated for myocardial blood flow reserve and perfusion. And one of the things with flurpiridaz is that you do have the ability to perform exercise testing. Exercise testing is theoretically better for MPI because you get the actual true assessment of what that patient's heart looks like when they are stressed and they are exercising. You get a more true picture of their natural vasodilation, and you get the exercise EKG along with it, as well as, evaluation of their symptoms and things like that. But this is also a slightly limiting factor for flurpiridaz, and because of the radiation exposure with PET, it makes it much more difficult and a little riskier for technologists to inject flurpiridaz in a patient while they are on the treadmill, because of the requirement of the staff and hospital or medical personnel to be in close proximity to the person on the treadmill. So the only two FDA-approved radiopharmaceuticals that are in regular use for MPI PET are nitrogen-13 ammonia and rubidium-82. Nitrogen, of course, is not used near as much because it is restricted to a cyclotron being on site, whereas the rubidium cart is fairly mobile. The indication, patient prep, and contraindications for PET MPI are consistent with those for SPECT imaging. I do want to point out, as far as indications go, that patients who have a larger BMI, a large dense breast, those patients should automatically be scheduled for a PET. It is a little bit restricted though by insurance pre-authorization and approvals, so that needs evaluated by someone on site. And then you want to position the patient supine with their arms up above their head. If scanned with arms down, you will get a beam hardening artifact from the CT, and this will look like streak artifacts on the emission scan that will be populated into the PET. And down here below, I have an example of the beam hardening artifact that you would see. So this image here is showing you where you would localize the heart and set your parameters for the CT or on the CT study. So you will obtain a scout to localize the heart, and then you will set the scan parameters. You want to make sure the heart is in the center. You want to have it kind of make sure that it's a little bit up from the bottom of the heart to make sure you're not clipping the apex. But especially if you're doing myocardial blood flow, you want to pay attention to the top too and make sure that you are able to capture the blood flowing to the heart. So remember, nitrogen-13 ammonia you inject as a bolus and scan it about 1.5 to 3 minutes. With rubidium, you infuse it for a maximum of 30 seconds. When you are doing that perfusion imaging, you may want to increase the scan delay in patients who have heart failure. So the left ventricular ejection fraction is above 50, then you'll scan it at 70 to 90 seconds after injection. So it's about minute and a half. If their ejection fraction is slightly lowered, you want to delay that a little bit to about 2 minutes post infusion. But if their ejection fraction is really low at 30% or less, then you may want to delay that up to 130 seconds post infusion. And the resting images are acquired over 3 to 10 minutes. Typically, you'll scan for 6 to 7 minutes, but that is slightly dependent on the scanner that you're using. After the resting pictures, you perform the pharmacologic stress. You'll inject the stress dose of the radiopharmaceutical at the appropriate time based on the stress pharmaceutical that's used. Lexiscan or Persantine are preferred, and you want to inject at peak vasodilation. The radiopharmaceutical is then injected immediately after that. And at the peak vasodilation. And then the stress image is acquired for the same amount of time as the rest. And remember that the dose is the same also. That's different from SPECT. And with nitrogen, you want to wait a minimum of 1 hour between the rest and stress injections to allow that nitrogen ammonia to decay. This table is showing you the differences in the PET perfusion tracers. Nitrogen ammonia is about 20 millicuries, and you scan them for about 10 minutes. With the rubidium, it says 20 to 50 on here. Sometimes you'll see it as low as 10 millicuries or as high as 60, and that is a little bit dependent on the generator that you're using and the scanner parameters. So it will vary a little bit on your protocol, but this is the typical dose. The scan duration is about 6 to 7 minutes. And with oxygen 15, it's 10 to 30 millicuries. Scan duration is about 6 minutes also. The half-life for that one is 2 minutes. And flurpiridaz, you give a little bit lower dose because the radiation dose with F18 is higher because of the half-life being so much higher. So typical dose for flurpiridaz is 6 to 10 minutes, and the scan duration will vary anywhere from 5 to 15 minutes. Again, that is somewhat dependent on the scanner that you're using. Now, we will cover cardiac viability in another video, another lecture, but I do want to talk to you just a little bit about cardiac viability because some protocols and some facilities will do a cardiac viability immediately following the MPI study. Some of them have them come back another day, but some of them it's part of the protocol. So on certain patients, if they know they order it, they can do it the same day, or they do a stress test with it when they want a viability. So I just want to discuss that a little bit with you. And the image that you see here is a nitrogen perfusion study followed by a viability. You see that the nitrogen perfusion has a pretty significant septal interior and inferior wall defect there, and the viability, it is perfused, so that shows you that is viable myocardium. So for the viability, it's FDG studies. This is a glucose analog. It's cyclotron produced. The relatively longer half-life allows for delivery over larger distance, so it's great for that. Method of localization is metabolic pathway, but remember, unlike glucose, it's trapped in the cells. It never gets metabolized or organified by the cell, and for that reason, FDG does not raise your blood glucose levels. The critical organ is the bladder wall, and the scan time post-injection has to be at least 45 minutes. Some places will wait an hour. Images are compared to perfusion images that were taken with nitrogen, rubidium, thallium, sestamib, or tetraphosphate. I do want to point out, though, that PET agents are preferred for comparison for viability with FDG, because the attenuation and the spatial resolution are so much better for PET over SPECT. Patients have to fast. When they are fasting, fatty acids are the primary fuel for the myocardium. The goal of the FDG viability is to encourage the heart to prefer glucose instead. And this is the reasoning behind glucose loading. So not everybody does glucose loading with viability studies. But if they are doing glucose loading, it has to be under the supervision of a physician, and the protocol is different whether or not the patient is diabetic. I have even seen some protocols where if they know the patient is insulin resistant, then they will change or modify that protocol a little bit to be more like a diabetic patient. Patient needs to be NPO for 6 hours. Oral glucose load of anywhere from 25 to 100 grams of glucose. This can be oral or IV. And if it's a diabetic patient, this is a particular challenge when you're glucose loading, and you will want to watch their blood sugar carefully, and you may need to give them insulin since they're not producing their own. So this is an example of a TEC sestimib rest with an F18 viability. You'll see that the viable wall in the second row here, or the third and fourth row, you'll see that there is a pretty significant inferior septal defect, and that does perfuse and fill in with the viability study. This is a perfusion metabolism mismatch, and this is a good thing. This means that the heart wall is viable, and this patient would benefit from revascularization measures. This is really important with patients who have a fixed defect on their myocardial perfusion studies. That viability study will help to differentiate the course of treatment for that patient. If they do have a mismatch and it shows that they have viable tissue, then that patient will benefit from revascularization measures, whether that's stenting or bypass. And if it doesn't, if it is a matched defect between the FDG and the MPI study, that shows that that is a fixed defect. That truly is infarcted tissue that is not coming back. It's not going to be reperfused. And so for those patients, they would benefit more from medical treatment or medical management. So this is the protocol for viability. And if glucose loading is not always done, but checking the patient's glucose before you start is. And then you want to inject when the optimal blood glucose level is achieved, which is about 140 to 150 milligrams per deciliter. You'll scan the patient at least 45 minutes after injection, and the scan will take anywhere from 10 to 30 minutes. This is an example of a glucose loading protocol. Notice it's different for diabetic versus non-diabetic, and it's very much dependent on their resting or their glucose levels. If their glucose is less than 150, you will give them oral or IV glucose and recheck it at 30 minutes. If it's 150 to 200, you give them a lower dose. But once their glucose is about 150 milligrams per deciliter, then you will inject the FDG. And notice if it gets too high, you can give the patient some insulin. With the diabetic patients, the ranges for what is an optimal glucose is a little bit different. And you'll notice that if it's greater than 225, you'll want to go ahead and give insulin instead of sugar and bring it down to where it's an optimal glucose before you inject. This slide is a little confusing, but it shows the acquisition parameters for NPI coupled with a viability study for whether you're giving nitrogen or rubidium. The injection rate for the resting scan is a bolus or bolus over 30 seconds. The FDG needs to be injected slow IV push. So Basically, what you do with that is you give the resting study, just like you would for resting MPI study. When the patient is done with either their whole MPI study or their resting, whatever your protocol is, but when they're done with the MPI study, then they will get injected for the FDG. Because they are all positron emitters and we're detecting the annihilation photons, we don't want any other PET agents in their system. So you want to wait until their MPI study is done before you inject the FDG. And then for the perfusion studies, we do gate those, but for the viability studies, we do not do those gated. Recall that earlier I said if you're doing MPI studies with CT fusion, this can cause a serious artifact if the CT emission images are not properly aligned. This is a perfect example here. You'll see where the red arrows are pointed in the first column. It's showing that in every slice and every view, you see that the PET images with the perfusion are overlapping outside of where the heart is on the CT. You always want to check the attenuation correction QC data on the screen in your scanner, in your perfusion software, just to make sure that it is overlapping and aligned properly. And you can adjust that if needed. Now, when you're adjusting that in CDERS or 4DM, when you're adjusting it on the processing software, you can adjust it, but it's not going to adjust the results. You actually need to adjust it and correct it on the scanner. So you would actually have to delete it from CDERS or 4DM, realign it on the acquisition software, and then send that back over to NVIA or 4DM or CDERS. And that way you would be able to now see it aligned. And that will affect the results when you do it that way. So you cannot realign them on the processing software. You have to do it on the acquisition. So on this left column, you see a misalignment where the arrow is pointing. It's outside of the myocardium on the CT. You see it especially prevalent in this coronal view. And then the corrected images are in the right column where you see that now it is correlating and lined up with the myocardium perfectly. This is another example of viability, and you see that in the resting, the anterior septal, anterior and lateral walls are showing a defect, but when you do the FDG viability, you see that that's actually filling in. Now, when you see, I want to point out something to you guys. If you see the inferior septal wall is perfused really well on the rubidium, but when you look at the FDG scan, it almost looks like it's not. That's because that area of the myocardium is healthy. That area of the myocardium is taking up fatty acids, it's taking up potassium, and it's functioning as normal. So it's not going to take up glucose. Glucose metabolism happens in the heart that is starving for blood flow, and it's not functioning normally. That's why it didn't get taken up on the perfusion study. So when you see an area like that that is perfused well on the MPI study, but it's not showing up on the FDG, that's a good thing. That means that myocardium is healthy and perfused really well. This is an example where somebody got their entire MPI study, rest and stress, and then followed with an FDG viability study. On this patient, you can see that there's a fixed defect in the septum and anterior walls and the short axis. And then on the horizontal long and the vertical long axis, you see that it goes all the way to the apex. It's more at the apex than the base. And same thing on the horizontal long. But if you look at the FDG study, it's not taking up glucose either. This is a matched defect. And you even see down here in the horizontal long axis, that area is completely missing on the FDG. That tells us that this patient is not eligible for revascularization. It wouldn't do any good for this patient because that is truly scar tissue. That is truly infarcted, dead myocardium. And so this patient would benefit more from medical management than intervention. And this is another example of viability. You do get some of the viability. It almost looks like the bullseye map, but it's telling you the percentage of viability by comparing the rest to the FDG study. It's showing you on this one, the patient has 40% that is actual scarring, and it shows you the extent of that as well. So this diagram is showing you normal versus abnormal. When it is completely normal, showing you that it is viable, normal FDG uptake, normal resting flow, and normal wall motion. When there is reduced perfusion, but increased FDG uptake and abnormal wall motion, that's a mismatch defect that tells you that tissue is viable. When you have a normal resting flow but reduced FDG uptake and abnormal wall motion, that's a reversible defect. It's considered a reversed mismatch. It's not taking up the FDG because it's perfectly healthy. It's taking up fatty acids. So in this case, it would be viable. And then if it's a fixed defect and it's matched and there's reduced resting, reduced FDG, and abnormal wall motion, that tells you that it is non-viable myocardium, and that patient should be medically managed. This is showing you the radiation dosimetry for different MPI studies. If you're using TEC-MIBI or tetrafosmin, the effective dose is about 51 millirems per millicurie. And so the total is about 1,500 millirems radiation dose to the patient. A lot of that has to do with the longer half-life and the pharmacodynamics of the technetium. Rubidium with a much shorter half-life, you could give a higher dose and the patient will get significantly less radiation exposure. You have 80 millirems versus 1,500. Even when you're using CT for attenuation correction, if you add the rubidium study with the CT, then that patient is getting about 520 millirems compared to 1,500 for the technetium study. And this is another example of viable myocardium. You look at the MPI study at stress and rest, and you see that there is a very large defect here that extends in the septum, anterior and lateral walls. And then if you look at the FDG study, that area perfuses. Again, if you look at the vertical long axis, you see its apex and anterior wall. And then when you do the FDG, it is filling in a little bit, but not a whole lot. You still see some activity missing around the apex. So PET cardiac imaging compared to SPECT. With PET, you have better resolution. You have decreased radiation exposure to the patient. It is a little bit more cost effective overall, especially because in the grand scheme of things, you have a lot of false positives and false negatives with SPECT imaging that end up pushing patients to the cath lab that don't need to be. So overall, it is a lot more cost effective when they're getting a better test and a better treatment plan that's more appropriate. Insurance reimbursement was a problem with cardiac PET. The COVID pandemic changed that a lot, just maybe the timing of it. It is improving a lot, and there are certain parameters now where the patient insurance companies recognize that the patient should have the PET procedure instead. People with increased BMI, certain history of coronary artery disease, some of those things, we know that cardiac PET is going to be a better study, and insurance is improving those. And then the treadmill is not routinely used. Flurpiridaz may change that, but for now, the rubidium is all pharmacologic testing. That concludes this lecture on myocardial perfusion imaging. Thank you for watching.